Welcome back to the Inside Scope. In a previous episode, we talked about the appendix. Today, we're continuing the conversation with Dr. Taylor and Dr. Boucher, shifting our focus to the gallbladder. Let's dive right in. So that's the appendix. Now, Dr. Boucher, we said the appendix is down there on the right. Where's the gallbladder at?
Yeah, we're moving a little further up and on the right side. Today's just right-sided belly stuff. Yeah. But so, yeah, the gallbladder lives...
What is on the left side, by the way?
Nothing important.
Stomach, the spleen. Yeah, that's my area, the spleen.
Oh, there you go, yeah.
So you got on the right side up higher is the gallbladder. We only have one gallbladder. What does it do?
So it essentially is a storage vault for bile that your liver makes. So your liver makes the bile. A lot of people think the gallbladder makes the bile, but the liver makes it and it stores it in the gallbladder. And when we eat, our gallbladder squeezes, pushes that bile out into our intestines. And the whole point of bile is it helps us digest fatty foods. Without bile, we could not digest fatty foods, and it would just come straight out of us with no absorption of nutrients.
Now, if I can remember back to many years ago, the amazing thing our bodies do is we've had bone doctors here talking about their specialty in bones. Inside the bone is the bone marrow. That's the center. And a lot of folks don't realize that in the bone you're making blood. Blood only lasts so long. Your blood cells last maybe 100 days. And then when they break down, the iron has to be saved. Your liver does a great job of that. But the hemoglobin, which some people may be familiar with that's the part that carries the oxygen. Isn't that what's turned into bile? So your body is conserving that, and it's that bile that the liver now uses to digest your food.
Yeah,
parts
of it. Yeah.
Mm-hmm.
So when we talk about the breakdown of blood cells, which is the natural cycle of the
they only
blood
last so
cells,
long. Yeah.
That process, one of the things that's created as it's broken down is what we call bilirubin.
Mm-hmm.
And that's present in our bile. That's what gives our bile its characteristic yellow-green color. It's also what colors our waste, our urine, and our stool.
Or if we're vomiting and there's no more food left, folks will say they're vomiting sort of greenish, bile-ish taste, horribly tasting stuff. And then it's that bile that's going to digest your foods. So with that, you got this gallbladder squeezing out. So what goes wrong? What causes some of these discomforts?
So it's two major things. I'm interested to know what Dr. Taylor thinks about the second thing. But so the number one that everyone talks about is gallstones, right? So some people are genetically predisposed. I think most people are genetically predisposed to forming gallstones. There's some other weird things like high amounts of calcium in your body, massive amounts of weight loss quickly, and things that can make gallstones form more quickly. But in general, it's just genetic bad luck. And those gallstones essentially block the gallbladder from letting its bile come out, and that's when we get into problems. The second thing, controversial thing, biliary dyskinesia, essentially where your gallbladder doesn't squeeze in one like nice concentric motions, kind of like a Charlie horse at your gallbladder where it's spasming randomly. Some people get pain from that. It's never an emergency like gallstone related stuff can be, but there's actually a divide in the surgical community about how real biliary dyskinesia is and if it should have surgery.
And would surgery make it get better? It's sort of frustrating, I guess, if you don't see the stones there.
Right.
So I know certain folks are at risk. We've just mentioned the ones that have lost a lot of weight suddenly could get gallstones. What are some other folks that, we do see a few more cases of gallstones or gallbladder problems in?
Yeah, so gallbladder disease is interesting. We have about 15 to 20% of the population in the U.S. is going to have gallstones.
Okay. That's the number I was going to say.
Yeah.
Of that 15 to 20%, that's probably about 20 million or so people. About 20% of those are going to have problems related to their gallstones.
Well, that gets to a future question. Right. If you know you have gallstones, do they have to come out?
Not necessarily.
Not necessarily. If they're minding their own business, not getting stuck. Are you looking at a certain size? Like if somebody says you got a lot of small little stones, or no, you got one or two big stones in the gallbladder, does that make a difference?
That goes into kind of what Dr. Boucher was saying. Is there's some nuanced decision making that goes into
and it's what the person is saying. They're having pain. They're having episodes.
Yeah, I think that might be a depends who you ask question. I personally follow if you have asymptomatic stones, it doesn't matter the number or the size or anything. That's the number one question patients ask me though. Is like, I have gallstones. How many I got? And it's kind of hard to tell sometimes on ultrasounds.
You can show them a picture sometimes.
Yeah, but you can't really tell a lot of the times.
I think what's so important here is that you're helping your patients become more informed, more empowered to say, yes, you have the gallstones, but here's what the red flags are. And the red flags, obviously, I think anybody would say severe pain. Any other red flags, like let's say somebody who knows they have gallstones and becomes pregnant, are you more worried about them as opposed to other people?
So that kind of ties into your question from before about what are our risks for it. Mm-hmm. Dr. Boucher kind of spoke on, there is a genetic predisposition. There are some people who are just
runs in the family,
prone to make gallstones. It runs in the family.
And you can ask your family members.
Absolutely.
Do you have, mom, dad, brothers, sisters? Do you have gallstone problems? Sometimes they may not have shared that, but you'd be surprised. Just ask if, respecting people's privacy.
Yeah. And then we also know, like we talked about, significant weight changes, either weight gain or weight loss is a risk for developing gallstones and gallbladder issues.
Okay.
And then also there's shown to be probably a hormonal component to it. We see symptomatic gallbladder disease is more prevalent in our female population.
And you're referring to estrogen and other hormones that are present in men
estrogen
versus
and progesterone.
Progesterone.
And so
okay.
During pregnancy, we do see an increase in gallbladder type symptoms, formation of gallstones, but also there's some other components. The natural flow of bile can be a little bit slower in the pregnant population.
I always hear the word sludge, things like that.
And that's not necessarily something that means, hey, we need surgery for, but it's definitely something that your obstetrician and your care team is keeping an eye on.
So much is going on at the same time. And
yeah.
We were talking about earlier that, okay, the gallbladder is located right there, but there's this thing called referred pain where your body doesn't quite know where the pain is coming from. Tell me about do people get pain in other parts of their body when they're having a gallbladder
and to
attack?
Me, this is honestly the hardest thing about seeing a patient with gallstones in clinic is, have gallstones seen on some picture, ultrasound, CAT scan, MRI, and then they're talking to you about their symptoms and trying to find out if those symptoms are legitimately from gallstones or if, tummy just hurts from some other reason. We get patients all the time. It's like, we have gallstones, but then I have pain down my left lower quadrant. And we're like, it's probably not that,
Yeah.
But yeah, gallbladder pain is known to be referred to we call the right flank, so kind of like the part of your back here.
You got your diaphragm really close to it.
Yeah, we think the nerves of your diaphragm sort of span out in a bunch of different directions. But yeah, so right underneath the right rib cage, right flank, and right shoulder, the three sort of classic spots.
So your mind is feeling that it's the right shoulder, but it's really your gallbladder. I mean, so if somebody's like, oh, my shoulder, is it tennis, is it golf? But it could be the gallbladder referring pain.
And what we see a lot, and I'm sure Dr. Taylor does too, if people come in thinking they're having chest pain from heart stuff, and it's actually just pain right here, and it's gallbladder kind of a lot, honestly.
Yeah, and the number one killer of women is heart disease and heart attack, and to see that somebody's convinced themselves it's the gallbladder, y'all are right there to say, now we're not going to just focus on one possible cause. There's many causes of belly pain. Heart can cause that, and I think that's a key thing, is picking that up and saying, I don't think it's the gallbladder. We need to have your heart checked out because you have high blood pressure or high cholesterol, a family history of heart disease, and yes, you may be a woman in their 40s, but we got to make sure heart disease is not part of that.
Sure.
And like what Dr. Boucher alluded to, when I talk with my patients, the gallbladder is a great mimic. There's so many different things that the gallbladder can present as that other things can present as. You can get chest pain, you can get reflux type symptoms, you can get people think they have, I had a bad meal and maybe it was food poisoning, and kind of teasing all of those out to make sure that when we take care of somebody, we take care of them for the correct reason in the safest way possible.
Yeah, and it's gathering all that information. And do you find as you get to know your patients that the gallbladder may have a surgical issue, but there's something that's making it more complicated, that you have to be a little bit more planning out ahead for a complicated gallbladder surgery?
Sure. And we're a complex hospital. We deal with complex patients from all over Florida come here for care for this particular problem. And we have different surgeons that deal with gallbladder cancer every now and then. Ends up being that we have patients who have tubes put in their belly to drain the gallbladder because they weren't a good surgical candidate, and we fixed that problem definitively. And I personally take a lot of pride in that we do things other people have said no to, because we have the organizational support around us to take care of those complex patients.
Because I see some of the patients at Lakeland Regional Health may have clearly a gallbladder liver issue and may have had something where they are not quite ready for surgery. And in fact, I think I was just reviewing a patient that did have to have the gallbladder drained. And I also hear about the cancer. If something's growing in there, there's a term we're probably going to discuss at one of our future shows, is a Whipple procedure. Is that more of a cancer type of procedure? Is it in that general area?
Yeah, so when we talk about Whipple procedure, the really mainstay of that is related to the pancreas, which is part of this system that connects.
So from liver to gallbladder, the tube is going right through the pancreas, and if there's a growth in the pancreas, that needs to be relieved so that the bile can flow.
And the good thing about where we are here is we have a very, very talented team of surgeons that can take care of the straight gallbladder issue, the oncologic or the cancer issue or the pancreas issue,
or trauma related that might have damaged the system.
And there's not really anything that we can't get down the correct pathway to care for where we are, depending on is it really, really simple or is it super, super complex.
Yeah, and then there's can wait a few days, wait a few weeks to get ready, but then there's this is an emergent. When you do the surgery, how's the team? Who else is there supporting you for those surgeries? Like, how long does somebody have to stay in the hospital after the gallbladder surgery, if it's pretty straightforward? And tell us about, is it a person staying in the surgical intensive care unit, particular part of the hospital? Tell us about those folks that are right there with our patients.
I think the evolution of how gallbladder surgery has changed, and since the late 1980s when we started doing laparoscopic or small cut surgery, compared to then and now, is a completely different ballgame for gallbladder surgery. Because back in the day, you used to get a cut from here to here.
Yeah,
you stay in the hospital 5 days and see you in 2 weeks in the office.
And it took a while for your belly to wake up, and you had a tube.
And we
in
see
your
the
nose.
Downstream effects of those incisions even now. If you get a big cut right here, it takes all the blood vessels that go to your abdominal wall, and your right rectus muscle totally atrophied over time. More scar tissue, more hernias, all
more
that stuff.
Hernias. And I think when we talked about that later, just to see, we talked about that before, the risk factors for hernias, and there's other changes. I didn't realize that, changing the blood flow with that.
You see on a CAT scan, someone who's had an open gallbladder in the past, the left rectus muscle, totally normal. This one, atrophied, tiny, shriveled. Whether or not patients feel that or not, I still think it looks interesting on CAT scans.
But here at Lakeland Regional Health, we have those abilities to do the smaller incisions, and that's called laparoscopic, meaning you're able to take a small scope and go in and do the surgery and be able to take care of that. That's how often, as far as the recovery, what's the follow-up like? Like, what do you tell your patients? You've gotten your gallbladder out. It was with the small little incisions, laparoscopic. What do you tell them to expect, and when do you see them again?
Yeah, so some of it, like everything, is going to be kind of patient dependent, why we're doing the surgery.
Their age, other medical conditions,
It's one of the most well-tolerated surgeries that we do. Oftentimes people are able to go home if it's a planned surgery. Say you met Dr. Boucher in the office. We found out you have symptoms from your gallbladder, but there's no infection or anything. We can have you come into the hospital, get your surgery done, and go home the same day.
Wow! And then I can see that first, the team that you have at the clinic, they sort of already know what are the common questions, get you ready to make sure that you can continue recovery with that. Any downsides to not having a gallbladder? Let's talk about some of the myths. There's a myth that you gain weight if your gallbladder has been removed. What's your thoughts on that?
That's funny you mentioned that. I just had somebody tell me that for the first time the other day. And I never heard that before.
I was figuring maybe because some folks connect the pain with eating, and if you remove the source of the pain, you might eat more. I'm not sure.
Theoretically, yes. Like if your life is awful because every time you eat a cheeseburger, you don't eat for 3 days because it hurts, and we take your gallbladder out and everything's better, like, yes, you
don't
you
keep
may
eating
gain weight,
cheeseburgers.
But don't blame us. I mean, we're helping.
No,
right?
it's like maybe you're more active now.
But I would say myth busted from like a physiologic perspective on that one. I would say that probably the biggest question I hear about gallbladder surgery is, am I going to have diarrhea forever? after. That's the one that patients ask me the most. Do you get that too?
I get my friend or my family
surgery,
member had gallbladder
Everybody
surgery.
knows somebody who knows somebody who knows somebody where they have diarrhea after.
Yeah, and so we do see, like we talked about earlier, one of the gallbladder's jobs is when you eat a meal with fats or grease in it, and everything has some form of fat in it. Your intestines send signals to the gallbladder to squeeze out some of this bile, and the bile salts and acids help break down and digest those fats.
Okay.
Initially after surgery, some people, a small subset of people, their body's not used to having that little extra oomph to help digest things. So if they eat a meal that's really heavy or really greasy, they may find themselves running to the restroom a little bit
There's not
sooner.
enough bile. So there's not enough bile. However, you're still making bile. It's just it's not being stored in the gallbladder, but the tubes are still from the liver to your digestive system are still there, going through the pancreas into your digestive system.
So my counseling to my patients is, after gallbladder surgery, for the first little bit, build into those really heavy meals, because some people have no issues at all. Some people do have some. Overwhelming majority of people that have a little bit of urgency after gallbladder surgery, that gets better as their body learns to adapt to not have it. Usually over, the first, 2 to 3 months or so.
Yeah, I would say after 6 weeks, the overwhelming majority of post-cholecystectomy diarrhea goes away. And I think the best literature we have suggests that diarrhea long-term, no more than 5%. I would say anecdotally in my clinic it's more like 1%, but you only know what you see sometimes. That's why we lean on medical literature to say, like, what is the rest of the world doing? It's probably more like 5%. And we have medicines to make it better.
Now, starting at the beginning when somebody's developing some discomfort, it might be in the shoulder, but the tests are starting to reveal that possibly you have some gallbladder problem. We talked about how the bile comes from the liver, can be stored in the gallbladder, but can also go straight through the pancreas and then right into your digestive system. Actually, I think it's a part just after the stomach, right? So now I bring that up because if you want to find out a little bit more about the gallbladder, is it common to have your colleagues in gastroenterology, GI, do a procedure? And I'm going to be hard to say what this stands for, but an ERCP. But often patients are just told this is an ERCP. What exactly is that, and is that a part of a person's gallbladder journey? They're starting to have some gallbladder problems. Do they find themselves that they need a little better information, or is this for something else?
I was hoping Dr. Taylor would say it.
Yeah.
Okay.
So typically when we talk about engaging our GI colleagues when we're concerned about gallbladder pathology, it's because it's turned into a complicated gallbladder pathology.
You need more information.
Yeah. The most common reason why we see it is we talked about you have these little gallstones that can form in your gallbladder. In some patients, those gallstones can move out of the gallbladder in those common systems that connect the gallbladder, liver, and pancreas together.
To the digestive system.
To the digestive system. If one of those stones gets stuck and blocks that system up, then we need to make sure that we can get that stone out.
Which is harder to get because it's deep.
It's down in around areas that we don't really like to do surgery.
We don't want to be there.
Unless we
Right, and your GI
have to.
partners, they can actually come from the mouth down into the stomach. The person is sedated, so they're calm, and you're able to take a scope with a camera and a light on it and actually go the other direction from the digestive system up, and they find the stone.
They can pull that stone out, and then it comes back to us to say, hey, this happened. How do we prevent it from happening?
Is it going to happen again? Exactly.
And the recommendation is if somebody has had, it's what we call choledocholithiasis or gallstone in that common system.
Yeah, not just in the sac of the gallbladder, but down the little
tubes. In the bile
tubes.
ducts.
It's okay. That can get stuck because it's a much tighter channel.
Right. Is the only real way to prevent that from happening again is to get rid of the gallstones.
Yeah.
Well, we don't have medications that can dissolve.
That's a common question. I'm glad you
Yeah,
brought that
there
up.
used to be medicines that would dissolve gallstones, but I always learned they were very rough, very dangerous.
Ursidile is like the poster
one.
child for it, and it had bad side effects and it didn't really work. And best case scenario, if it worked, the stones would just form again. So there's no point.
And I have to say, when you're at this point that you know you have stones, they might have taken one out, but you might have passed one, and you have others. What about these myths of olive oil or lemon, or these myths of if I take this, I could dissolve my gallstones. Are there things out there, or you get asked about that?
Yeah, well, I unfortunately take the bait of following the rabbit hole down social media stuff of cures you can do at home for gallstones, and olive oil, like vinegar cleanses and stuff,
Epsom salts,
all that stuff. It's so weird because like your gallstones never come in contact with your GI tract, so I don't understand why people think like that is going to like be your solution, like flush it out with something. And a lot of people confuse it with kidney stones too. I get this a lot, where it's like, well, can't just go and take the stone out and then we're all good, right? It's like, well, no, not really.
You drink a lot. Fluid goes through your kidneys, but that is not what's happening with your gallstones. So
different
flushing,
kind of stones,
and it's not a connection that's going to work. So that's a key thing, is that you're able to answer the common questions that I think patients have or see, and they can gather, well, this makes sense because you're the experts, being able to say, this has come up commonly. Here's what you should or should do. But here, it's all right here at Lakeland Regional Health. You're able to find all that information, know how to go forward.
Yeah, and we're very blessed because, that ERCP procedure you mentioned, we have very talented gastroenterologists who can do that procedure. We get a lot of transfers into this hospital system to do that when it can't be done elsewhere.
Right, because the ERCP is basically going through the digestive system and looking into the gallbladder system and saying, oh, here's the stones.
And it's a complex procedure you need additional training for to do, and we're blessed to have that here at Lakeland Regional. And I will say, kudos to like Dr. Taylor and his group, because if you come in with a gallbladder attack in the middle of the night, like that's who you're going to see. Like they are seeing you, evaluating you, getting ready for surgery as soon as possible, and we're very lucky at this hospital.
Both appendicitis and cholecystitis, you're there 24 hours a day. We have that, and even showing up at our freestanding emergency room, they're going to recognize it because there's some of the tests you can do, the CAT scanning, which can be done at the freestanding ER there on 540A and South Florida Avenue, but also you have the ultrasounds. What do you find is most useful with gallbladder disease right then and there? What do you think?
So classically, it's ultrasound is the best to look at the gallbladder,
because you'll see the gallbladder, you'll see the stones.
We'll see the stones, and we'll see inflammation around it. CT scan for everything that it's really good at. A lot of times it can kind of fall short with looking at the gallbladder, because the gallstones they don't tend to have enough calcium in them. They tend to be more cholesterol, which the CT scan can't really see as well.
And some of our folks that are listening to this could also remember something called a HIDA scan, HIDA. So a HIDA scan was a way of sort of trying to get the gallbladder to act. What was that? Do you still use that test?
So we do. So the HIDA scan works by an IV kind of radio tracer medication is given.
That will show up on photographs that are taken.
Show it up on the photograph. We can see it go. It goes into the bile, so we see it go into the bile in the liver, and then we can follow it go into the bile in the gallbladder, and then we can follow it go into the bile into the GI tract.
So you want to see what you're expecting to see, normal functioning, and then you can see if it's contracting. Well, here's the big question: is like, I'm going for gallbladder surgery. Do I get to keep my gallstones?
Oh, this is
do you ever get asked that?
I would say 1 in 20 people ask me that.
Okay.
And I mean, I say yes. I don't know. It's your stuff. You can have it if you want. Yeah. But I will say that there are kind of two varieties of stones. One's more of like a cholesterol, like squishy. You can squeeze it and just kind of disappears.
Why would you want to keep that?
Like putty. Yeah, why would you keep that? And the other one's the calcified bilirubin ones. Those are kind of cool. Like those are like you clink them around in the bucket and stuff. And like I've heard people say they make earrings out of it, random stuff. It's weird, I think, but it's their body.
Yeah, it's good to ask questions. There are certain rules to make it safe, and you want to ask ahead of time, just to know the process of it, because we always are making sure we cover all the bases. I think when you take out a gallbladder, do they double check to make sure there's not cancer in it, or do they check it with what they call pathology?
Yeah, absolutely. Our practice is anytime we do surgery, we make sure that we look at it under a microscope. Common things being common with gallbladder, the pathologist will look at it under a microscope. It takes about 3 to 4 business days, so you'll be long home. It'll be something we can talk about in the office.
Yeah, and did you find inflammation? Did you find anything else in it, or did you just find what you expected to find?
Yeah.
Well, I really appreciate you and your team, both at the clinic and the surgical intensive care units. And is it Bravo 7? Is that the floor where your patients, if they have to stay a day or two?
That's where they would stay.
Yeah, there's a great team up there. Hey, thanks a lot for all the information. I think I understand a little bit more about the gallbladder and the appendix, and certainly share this with the folks that maybe you know some high school students that are thinking about careers in healthcare. They're the folks that are on your team and can go further with that too. Hey, thanks a lot. Appreciate it.
Thanks, Travis. Appreciate it.
Hey, thanks a lot. Thank you.
Absolutely.
Extended eye contact.